Okay, this is Andrew Bennett again. I want to move on now to discussing validating the intern and elevating the patient's experience. Um, the cardinal rule in improv comedy is to never disagree with your partner. So if Rob or John and I are sitting in a theater and we get called on to do an improv comedy, and John goes up there and he says, "Hey, Andrew, did you see the purple dinosaur in the bathroom?" And I respond, "No." I've killed the momentum. But if I respond with, "Yes, and yes, and did you see that he had green and purple spots all over his left foot?" Then it shifts the direction of the conversation, but it doesn't kill the momentum. And that's really what you want to do in your discussions with the interns, especially when you're in front of the patient, which most of our discussions will occur in this model in front of the patient, because ultimately what we're trying to do is elevate the patient's experience. Um, you know, you and I will often have thoughts on how to categorize their low back pain, or using tissue test to rule in or rule out neural structures, but we don't relay that to the patient. All they see and hear and feel is you wiggling their arm and then telling them how you want to help them. Um, so by having the intern involved, it adds a step of transparency and invites the patient to participate in the discussion around why and how we arrived at the decision to guide us into treatment. Example would be when a intern would be finished with their history and physical exam, they would come and get me, and they would say something along the lines of, "Dr. Bennett, this is Jeff. Jeff, this is Dr. Bennett. He is our clinical faculty." "Hey, Jeff, how are you?" I'd interact with him for a second. "It's good to see you. I'm glad you're here. Now, John," it being our intern, "John, tell me what you found out about Jeff." And I would be sitting next to Jeff and just sort of listening now to the intern John tell me about Jeff. And so, the intern would go through his physical exam in the rounds format that we use. It's outlined in the PowerPoint. And then during this time, I'm saying yes to the intern. "Oh, okay, good. Good, yes. Jeff, does that sound right?" So we're bringing that patient in. And when the intern comes and arrives at their hypothesis, and you can then say, "Okay, well, what test did you choose to confirm your hypothesis?" And they said, "Well, I used the test item cluster to rule out cervical radiculopathy." "Ah, very good." Do you see what I'm getting at? Is that now we're allowing that patient to sort of participate in the improv comedy, if you will, the improv theater that's happening around them. Because ultimately our goal is to change their experience, so that when your patient walks out of your clinic, in fact, before you even put your hands on the patient to treat them, the patient is beginning to get better. Because they're listening to the story, their story, unfold around them. You are telling them their own story. And they're getting it. And they're saying, "Oh my gosh, I've never in my life been to a healthcare provider who gets me, who understands my body, who understands what my needs are. And holy smokes, these guys are different. They know what they're doing." So not only are we going to be able to build our brand and expand our markets in terms of our patient and our client base, but we're going to change the way the patients engage and understand physical therapy. One of the things that I will often do is use the yes and phrase when the intern is wrong. For example, let's say that the patient presents with a primary complaint of plantar fasciitis, and the intern failed to look at a straight leg raise. So for whatever reason, they just forgot. So the intern is telling me that the patient has plantar fasciitis, and he feels like that it's more of a a tightness in the heel cords, some needing to work on closed-chained balance and control. Um, and when I ask him about, well, did you look at the straight leg raise yet? No, I didn't. Okay, well, let me show you how the straight leg raise might be helpful in better treating patients like this with plantar fasciitis. So again, I'm trying not to be overly theatric here, but I think you get the idea that we're saying yes and, not no, you missed something, but yes, you're on track, and let me add a little bit more to your understanding here. Um, Even when the patient is, even when the intern is absolutely dead wrong. For example, let me think of something. They're not often dead wrong, but for example, let's say that the intern is really lost and says that feels like their low back pain is coming from their SI joint. Feels like he has a posterior nominate or a sacral torsion. Let's say they're just really out in the weeds somewhere, and you can respond to that with yes, that's very likely that they have some back pain related to the sacral joint. But even when patients have sacral pain, they still are included in the classification system. So even if this patient has some of these symptoms sort of pointing to this area of their back, we still want to use the best evidence of classification. So let's go through those together, and why don't you tell me which one of them he fits in best? So again, you see how we're not telling the intern he's wrong. We're saying, yes, you do have pain here. Yes, I can see how you made some decisions around the sacral area, but without feeding the patient pathoanatomic lesion knowledge, I'm guiding the intern through the classification criteria and allowing the intern to make the decision, and so the patient feels like that the intern isn't, didn't make a mistake, but was simply guided to the right answer by the clinical faculty. So that's something I feel is very important. Now, it's easiest to do during the initial exam. Where it gets harder is on subsequent visits. But it's incredibly important for you as the clinical faculty member to touch base with every intern's patient on every visit. One of the worst things that can happen to your clinic is for some comment like this to get back to your referral sources. Yep, I saw the doctor one time, or I saw the physical therapist one time, and after that I was with the intern. I never saw him again. Bad all around. You have not elevated the patient's experience. But what you can do is make a point to touch base with that patient and say, hey, Jeff, how are you? How's the family doing? The stuff that you normally do. But then, John, did you ask the intern? John, did you have you gone through the 5-question follow-up yet? Yes, Dr. B, I did. Okay, are we on track, or do we need to change anything? No, Dr. B, I think we're on track. In fact, I'm going to go ahead and manipulate the lumbar spine again today. Good. Jeff, sounds like things are on track. Would you agree? So, again, something where you're engaging the patient, involving the intern. I will often use words like, hey, Jeff, John and I, my intern and I, John, have been talking about your case, preparing for today's visit, and he's going to be changing some of the exercises based on some things he and I have talked about. You be sure and let either him or I know if there's any discomfort or difficulty with those. In other words, I talked about your case before you even got here. And the changes that are about to occur are ones that I've helped initiate or authorize. See, one of the things that has I've learned about this is the patient needs to understand that although the intern is doing the stuff, if you will, that the clinical faculty, the guy, the girl, the boss, the FA, is driving the care. And it's not about me, the clinical director or the clinical faculty, having an ego complex or needing a constant pat on the back. In fact, it's absolutely the reverse. In fact, I would feel the more humble you can be, not self-deprecating, but humble, but confident, and offering knowledge, offering feedback, the better your patient's gonna be able to respond to the care delivered by the intern. But you and I and the intern all know that the intern's making the clinical decisions. I mean, that's the whole rule. That's the whole desire. So, validating the intern, elevating the patient's experience. Again, if you go to Moodle, there's some components here: servant leadership, humility in teaching medicine. I think these are helpful. Um, uh, just some other resources there. I would encourage you, like always, if you have resources that you find are helpful, whether they're video clips, TED Talks, things, PowerPoints that you've put together, a short rant like what I've done, please feel free to add that in because, again, collectively we are going to be developing the next generation of physical therapists.